Welcome to Doctors on Call. I'm Jenna Miller. As the saying goes, some things never change. But did you know that includes the size of your eyeballs? From birth to death, a human's eyeballs remain the same size. The human eye is made up of more than 2 million working parts, and 80% of what we learn is through our eyes. Given the complexity of this fascinating organ, it's no wonder eye care should be at the top of our self-care regimens. Patients are encouraged to see their optometrist regularly, and we'll be finding more on that as we speak about eye care tonight with our guest, Dr. Kendall Krug.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from at Blue Cross Blue Shield of Kansas. We're committed to being a healthcare partner you can turn to. That's why we're simplifying the health insurance experience so you can feel more empowered in your health.
Hutchinson Regional Healthcare System. Our family caring for yours.
At Osborne County Memorial Hospital, our services range from clinic visits to inpatient and skilled care, but our specialty is you.
Your family is our family. The staff at Smith County Memorial Hospital wants to set the standard of excellence for healthcare in north central Kansas.
Russell Regional Hospital, experts, neighbors, friends.
Dr. Kendall Krug is a native of Hays, Kansas, and graduated from Fort Hays State University. Dr. Krug received his Doctor of Optometry degree from the Southwestern College of Optometry in Memphis, Tennessee. He completed externships at Children's Mercy Hospital in Kansas City and Nellis Air Force Base in Las Vegas, Nevada. Dr. Krug is a diplomat of the American Board of Optometry and currently is in private practice in Hays, Kansas. Give us a call at 800-337-4788 toll-free with your medical questions about eye care on Doctors on Call. Doctors on Call brings you information which may be useful to you when you see your own physician or specialist. Thank you so much for joining us tonight. We got lots to cover, so let's get going. First of all, when you examine someone's eyes, what diseases are you looking for?
Well, we look for many different things. A lot of times they're not evident. We're doing an examination just of the eye, but that can include many parts of the body. Certain diseases may show up in the eye or have visual symptoms, and while it may seem like it's just with the eye, there's a lot of different things that need to be ruled out. And it's not uncommon to find diabetes first in the eye. Different conditions that can cause blurred vision can be neurologic to something like a cataract, but many times it may not be an eye problem itself. So there's a lot of things to contemplate, and you need a good history from the patient, and then ask the right questions, and then do the exam.
Is it true that your eyes are like a window to your brain?
Yeah, the retina is actually considered part of the brain. It's connected. There's over 120 million separate retina cells in the retina that are connected through the optic nerve to the brain. And each one of those retina cells has a specific area in the visual cortex, the back part of your brain, where the vision is actually registered and perception occurs.
How often should a person have their eyes examined?
Yep. Depends on age, depends on what's going on, but for the average adult patient, up till 60, about every 2 years if they don't have any other medical conditions. Children, we like to see every year if they have some kind of visual problem. Certainly we want to see kids before they start school, or if the pediatrician or family doctor sees some kind of eye signs that are concerning. After 60, we want to go every year. Again, if there's diabetes or other medical conditions that might warrant seeing more common or more often, maybe every 3 to 6 months.
Now we're still unfortunately in the midst of COVID. Can COVID affect a person's eyesight?
Yeah, I was going to talk a little bit about that.
Sure.
This time of the year with the dry conditions and the wind, and more recently with all the smoke, a lot of things we're seeing in the office right now are conjunctivitis or inflammation of the outside of the eye. And conjunctivitis can be environmental, like smoke, and people would have red, irritated eyes, but it would be both eyes at the same time. It's because it's not infectious. But there are diseases like pink eye. Well, what's pink eye? Well, that's an infection of the eye. And typically infections start in one eye and then spread to the other. a bacterial infection, when people think of pink eye, they think of the gooey, pussy eye, that the eyelids are stuck in the morning, and if you've had kids, you know all about that, and that's a bacteria on the skin. So we typically we'd see a patient come in, red eye, puffier on the lids, and they would say their eyelids are kind of stuck in the morning, burning sensation. That's treated with an antibiotic. Typically that will spread to the other eye within a day or two. Now viruses, and kind of to your question, viruses are also infectious. A lot of times they're adenoviruses from sore throats and upper respiratory infections, but respiratory infections include COVID now. And viral eye infections will start in one eye again, but it will take 7 to 10 days to show up in the other eye. Interesting enough, we've seen several cases of COVID conjunctivitis, and you go through the same history that, you know, it started in one eye, got it in the other eye within 7 to 10 days. A lot of times they'll have positive lymph nodes in front of their ear. You know, unlike bacteria, viruses, we have fewer antiviral medicines that will treat a pink eye. And so that's been the problem. We don't really have a topical antiviral that we can use. Off-label, we can use betadine, which is an eye wash that's used for surgery, and it will pretty much clean up any bacteria or viruses. And so the cases I've seen, basically they pan out as being some kind of viral conjunctivitis, and then you ask the patient if they'd had any exposure. Studies have now shown that about 9 to 10% of the COVID cases are spread through the eyes or through the conjunctiva, and some of the newer variants less so through the nose and maybe more through the eye or through the mouth. So there's a lot to think about, but you can get COVID through an eye infection, and so that needs to be considered.
Interesting. How does a person protect themselves from transmitting from one to another?
Well, it's by direct contact. It's not gonna, you know, you're probably going to touch something that has the virus on it, or touch somebody else, or they touch you, or more likely at home with one of your children or something like that. So you're going to spread by touch, and that's pretty typical of any viral eye infection.
You had mentioned with the smoke and the wind and dust, you had mentioned dry eye. Mm-hmm. What is it, and how can it be treated?
Dry eye, the eye is surrounded by a mucous membrane, so it's kind of like the inside of your mouth or your nose. It produces moisture through different types of glands, and there are oil glands in your eyelid, there are mucus glands on the white of your eye, there's a lacrimal gland that secretes a watery secretion, and in a good eye that doesn't have dry eye, you have a good balance of all three of those. Well, out in western Kansas, when the wind's blowing, you tend to have more evaporation, so you're losing one of those components of the tear film. And once the eye gets dry, it's more prone to infection. You're going to have irritation from the smoke and other things like that. So a lot of times you can say, you know, pink eye may actually start as just dryness. And so somebody calls in and they say their eye's been red and irritated, probably both of them at the same time because it's in the environment. And so a good place to start at home would just be start using lubricating drops at least 4 times a day. And if that doesn't seem to improve it, or if you actually start to get a discharge, then you need to probably seek out your medical care with your primary care eye doctor to see if it is an infection. You know, once you get discharged, then it's probably infectious.
Is there any truth that there are nasal sprays out there that can help with dry eye?
That's true, yeah. There's a couple of new medicines out there that we want to talk about. Tyrvaya is a new one. And if you've ever heard of the medicine Chantix, which is for weight loss, this is the same medicine, and it's a nasal spray that you spray up your nose twice a day, and it stimulates the trigeminal nerve in the nose, and that innervates the tear glands. So it's basically a stimulant that causes your tear glands to secrete more tears. So yeah, I've tried it in a couple of patients, and it's worked very well. But it's very expensive. It's a new medicine, so you know, a nasal spray that costs $500 is tough. So if you're lucky enough to have commercial insurance, that would be a way to go. Dry eyes typically treated with over-the-counter drops like Refresh or Sustain, and so that's usually where we start. There is a place for oral fish oil supplements have been shown to increase the fatty acids in the body and increase the oily secretions of tears. Restasis has been out for many years, and that's an eye drop that directly stimulates the tear glands to secrete more. And it has a little bit better insurance coverage. And Zygra is similar, works the same way, but it's actually a drop you're putting in twice a day that stimulates more tearing. And it works for a lot of people, but usually we'll give them a trial of maybe 4 to 6 weeks, maybe up to 3 months to see if it makes a difference. The Tyrvaya, though, works immediately. So it doesn't really irritate the inside of your nose, but it'd be kind of like sniffing onion fumes, and it makes your eyes water. So it kind of works that way. And it does make you sneeze. That is the main side effect that people report. About 80% of people report, sneezing after they do the puff in their nose.
Okay. What types of contact lenses are on the market right now?
Contact lenses, yeah. I mean, I brought some samples here to look at, and contact lenses started a long time ago, back in the 50s and 60s, with hard lenses, and these were just made out of a polymethyl methacrylate. Very good optically, but they didn't breathe, so oxygen couldn't get through those. So there was a limited amount of wearing time. Then in the late 70s, the polymer chemistry developed what are called gas permeable lenses. So the silicone was put in the polymer, and so oxygen could actually pass through the lens.
Oh no, I was just going to ask you to. There we go.
Mm-hmm.
Okay, go ahead. You can keep.
This is actually a special lens that we use for people who have had interest in refractive surgery, LASIK surgery, where a laser is used to change the shape of the cornea. This is a corneal refractive lens, and this is a lens that you put on when you go to bed, and it actually changes the shape of the cornea by the amount of the nearsightedness you have. So it only works for nearsightedness, but on younger people especially, you put the lens in at bedtime and you take it out in the morning, and you basically can see all day without glasses or contacts. And unlike LASIK surgery, it's reversible. So if you decide you don't want to do it anymore, you stop wearing them. So and your eye just kind of goes back to its normal shape. So that's a rigid lens. Most people are more familiar with soft lenses, and these soft lenses came out in the early 80s, late 70s, early 80s, and basically it's a polymer that has moisture in it. It's also the new ones are now silicone, much bigger, but that actually makes them a little bit more comfortable on the eye. Optically, we can put nearsighted correction, farsighted correction, astigmatism, bifocals. There are soft lenses that you use for a month. There are soft lenses that you use for 1 day, daily disposable. So disposables are definitely what we do these days. Whether you replace them every 30 days or every day kind of depends on lots of different circumstances. Daily disposable is nice, but it costs a lot more because you're spending more money on contacts. So that's an AccuView lens, pretty standard looking one. Then there's some more exotic lenses. The downside of a soft lens is it's flexible and it doesn't hold its shape, so it's optically not a good material. Your eyeglass lenses aren't flexible; they hold their shape, and that's how good optical surfaces work. Well, what happens if you could take a soft lens and put a rigid lens in the center of it? So that's called a hybrid lens, and this is a synergized lens. So we get the sharper optics of a gas permeable lens, but it feels and fits like a soft lens. And we can fit higher amounts of astigmatism, sharper vision. We can do bifocals in those. Very, very interesting lens. And it's really, people with very high prescriptions, especially astigmatism, I've had some wonderful outcomes using lenses like this, and it's very comfortable for the patient. Not really a disposable. You replace these like every 6 months, and you do have to care for them, so you would have to put them in a case with some kind of disinfectant. The last one I brought tonight is something very new. And if you can imagine putting this in your eye, this is called a scleral lens. So this is actually a gas permeable lens, so it's very large, but it doesn't set on the cornea, it actually sits on the white of the eye. So that's why we call it a scleral lens. So because it doesn't touch the eye, you put that in your eye, you can't even feel it's there. And since it's larger, we can put more optics in it with a larger optical zone. We can do high amounts of astigmatism. I've had some patients lately that had distorted corneas from diseases like keratoconus that they cannot see clearly with glasses because glasses don't correct irregular astigmatism. Have had patients that have had RK surgery back in the 70s. That was the original refractive surgery that was developed in Russia, where they sliced the cornea, radial incisions. Well, those people get to 70 years old and their cornea starts to degenerate. And I've had patients that the best they could see with glasses would be about 2100. You put a scleral lens on, the tears fill in the irregularities, and they can see 20/20, which is pretty amazing. So, and those are more of a permanent, but they are gas permeable, so they go on the eye. I've had patients that farm with those, and believe it or not, even out in the dust, they're very more comfortable than they are with a soft lens. So, pretty amazing.
Very amazing,
Yeah.
very amazing. Great information. We want to remind our viewers that we are talking about eye care tonight with Dr. Kendall Krug from Hayes. And having said that, we have Yvonne on the line from Great Bend ready to ask a question. Hi, Yvonne. Go ahead with your question for Dr. Krug.
Yes, I have severe dry eyes, and I woke up with itchy eyes, and one afternoon I had this large floater. I've had little tiny ones that look like gnats, but this was a larger one. Is there anything that would have caused that, or is that just something happens with age? Is there anything I can do about it?
Well, floaters are a very common complaint. That's actually structures on the inside of the eye typically, so I wouldn't say that that's due to dry eye. However, floaters that come on suddenly, we need to be concerned about retina detachments and retina tears. More likely it's something called a vitreous detachment, which is a very common thing that happens in our 40s, 50s, and 60s. If there's been trauma to the eye, we need to be concerned. If besides the floaters, usually if it's a vitreous detachment, there'll be a big, large floater that will suddenly appear, but there's no flashes of light, and you typically get used to the floater after a while. There are ways to surgically remove floaters, but it's a fairly high-risk procedure, and there are now ways to use a laser to break the large floater up into small ones. So the advice for you would be go see your eye doctor. Anybody that has a sudden onset of a floater, you need to have your eye dilated, and they need to look inside and make sure that it's nothing serious or sight-threatening.
Okay, I want to go back for a minute with the contacts, and I would like to ask if there's anybody who is not a good candidate for contact lenses.
Not a good candidate. Anybody in Western Kansas. You have to have a significant moisture in your eye. So one problem is if you have dry eyes. So as we get older, typically our eyes get drier. Now, interesting, the scleral lenses actually do pretty well on dry eye patients because they hold a reservoir of saline solution or tears between the cornea and the front of the eye. So that it can actually help in those cases. But if you don't have enough moisture to support these lenses, and remember the soft lenses are 50 to 70% moisture, and that moisture is coming from your tears. So that is a contraindication if your eyes are not moist enough. Certain eye infections, inflammation inside the eye are contraindications to wearing contacts, but those are typically things that come and go. But the contact lens wearing years we kind of run out of that ability to wear. However, I've had 80-year-old patients that wear rigid contacts, and maybe they have to because of the vision correction that they need. But it's always something you can try and see if you can support the lens.
Sure. If a patient has a sign of decreased or distorted vision, what is the next step for treatment?
Well, distorted vision is always a concern, especially if they had normal vision and it suddenly changed. So basically we start at the front of the eye and look at the cornea, check for cataracts, look into the back of the eye, look at the retina. There can be circulatory, there can be neurologic conditions that can cause change or loss of vision. So the history and of the condition, how the symptoms started, was there trauma, things like that. There's just 100 different questions you have to ask to start narrowing it down. But it basically starts with looking at the eye, finding out what that person can see. Is it one eye? Is it both? and then looking at the eye and trying to determine out what the problem is or what's causing them.
And you mentioned cataracts. Let's talk about that a little bit, what it is and where someone goes from there.
Yeah. Cataracts are very common. That's the cloudiness of the natural lens inside your eye, which we all have. That lens is what's responsible for allowing your eye to focus up close for the first 40 to 50 years of your life, and it loses out of that ability. That's when you have to start wearing reading glasses or bifocals. Then you add another 10 years, you get into your 60s, and then the lens actually starts to get cloudy. When it gets cloudy enough that you have difficulty seeing through it or have glare, then you have cataract surgery. Cataract surgery is the #1 surgery done in the United States. We have many cataract surgeons in this part of the state, and they do a lot of cataract surgeries. So the cloudy natural lens is removed and an artificial lens is put in. Interesting, the artificial lenses that we put in now can include bifocals. They can correct astigmatism. I've had 50-year-olds with very high corrections that didn't have cataracts that we went ahead and did a clear lens extraction so they could get the benefit of the implant lens that will permanently correct their vision. So there's reasons to do it even if you don't have cataracts, but typically it's a 70 to 80-year-old person that their vision is no longer adequate for reading or driving.
Excellent. What are the early signs of a detached retina, and how's that treated?
Detached retina. So the caller that talked to us about the floater, sudden onset of a floater, and typically there's going to be flashes of light too, so kind of like lightning flashes or welding, and you want to try to, it's going to be in one eye, so you have to try to determine if it's one eye or both. So that's one place we start. But if a person is complaining that suddenly there's a floater there, and typically they'll say it's not one big floater, but it's hundreds of little black dots. And those little black dots are actually blood cells floating around in the vitreous. After the retina tears, it will tear a blood vessel and there'll be a hemorrhage inside the eye. And so typically the call you get is on a weekend. Maybe there was an injury to the eye. All of a sudden there's a painless flash of light, and then we start seeing all these floaters, and they'll typically increase. Whereas the vitreous floater, it happens and it doesn't really get any worse. So it's something you don't want to sit on very long. If you were having a detached retina right now, you'd be heading to Wichita tomorrow for surgery.
Okay. What is LASIK surgery, and who might be a good candidate for that?
Yeah. LASIK surgery is one of the refractive surgeries that have been developed over the last 25 years. And basically, we're just changing the shape of the cornea. And you're changing the shape of the cornea by the amount of the nearsighted correction. So if you wear like a -2 correction, they need to change the curvature of the cornea by 2 diopters. Now, there is a difference between LASIK and PRK surgery. And I prefer PRK for my patients. They use the same laser. They're changing the center layer of the cornea called the stroma. They can change the curvature of that very precisely. With LASIK, they're slicing off the top layer of the cornea called the epithelium, and then they put it back on. With PRK, it's removed completely and then lasered, and then you put a bandage lens on, and it takes a couple of days for it to heal back. That is much more stable long term. I've seen patients, and that's what the military uses for their pilots is PRK. So anybody that can do LASIK can do PRK. PRK is maybe just a little bit easier to do, and the results are much more stable.
And we have a cardiologist coming in next week. How might high blood pressure affect your eyes?
High blood pressure, uncontrolled, damages the small arterioles throughout your body, and you have those in your retina. So you can tell somebody that has hypertension by looking at the retinal blood vessels. And basically the blood vessels thicken, and so you lose blood supply to the inside of the eye. The retina needs a lot of blood supply to keep functioning. It's the most metabolically active tissue in your body. So if you're not getting good circulation due to high blood pressure, and you may not have a lot of symptoms, but what will happen is a sudden loss of vision, like a stroke. And you can have occlusions of the blood vessels in the eye, and it's just like a stroke in your brain. That part of the retina dies and never regains function. So yeah, high blood pressure is a big deal. You want to make sure that you keep it under control to prevent loss of vision.
Okay. Well, our thanks goes out to Dr. Kendall Krug from Hayes for being our guest on Doctors on Call tonight. As I just mentioned, our next Doctors on Call will be discussing heart disease. You can email questions to us for our next program at doctors@shptv.org. Thank you for joining us for Doctors on Call. I'm Jenna Miller.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from At Blue Cross Blue Shield of Kansas. We're committed to being a healthcare partner you can turn to. That's why we're simplifying the health insurance experience so you can feel more empowered in your health.
Hutchinson Regional Healthcare System. Our family caring for yours.
At Osborne County Memorial Hospital, our services range from clinic visits to inpatient and skilled care, but our specialty is you.
Your family is our family. The staff at Smith County Memorial Hospital wants to set the standard of excellence for healthcare in north central Kansas.
Russell Regional Hospital, experts, neighbors, friends.